Hi, this is Dr. Diane Gayhart, and this is my lecture on solution-focused therapies to accompany my Cengage textbooks that include Mastering Competencies in Family Therapy, Theory and Treatment Planning in Counseling and Psychotherapy, Theory and Treatment Planning in Family Therapy, and Case Documentation and Counseling. There are actually a few distinct strands of solution-based therapies. There are three main strands. The first is solution-focused brief therapy, and this is definitely, I think, the most widely known. It represents the work of Steve DeShazer and Insoo Kim Berg, and so this is a very specific form and probably the first solution-focused therapy. Solution-oriented therapy, it was developed by Bill O'Hanlon and Michelle Weiner-Davis. And this is actually, I would say, a more language-based one, where solution-focused brief therapy has some more specific and often more active-based approaches. And then there's also solution-oriented Ericksonian hypnosis, which we will touch on briefly. But it is a hypnosis technique. It's a very light trance. It's not like what you'd see in the movies, you know. But it's a part of the solution-based therapies out there. But all of these are so similar, and I certainly think in the 21st century that when people talk about solution-focused therapy, they're talking, drawing from at least the first two of these different strands of solution-based practice. So we'll be talking about them as solution-based therapies or solution-focused therapies, referring to at least the first two approaches here. And this lecture just kind of hits the highlights that are in my solution-focused chapters in various textbooks that are available from Cengage and other book realtors. And you can actually find the clinical forms that go with this textbook series on my webpage called masteringcompetencies.com that you should see on the homepage for YouTube, so that you can get tons of free resources related to these texts. So we're going to be talking about solution-based therapies. So in a nutshell, what do you need to know about solution-based therapies? The first is that they are strength-based therapies, and arguably they were the first and probably I think still the best representation of strength-based therapy that you'll hear a lot of. It really is a buzzword in the field of mental health today. And the idea here is that you spend a minimum of time talking about problems specifically, and we'll go more into this in a moment, but the basic idea is that the solution isn't always related to the problem. And so you can talk about, depression ad nauseum, but that, what it means for that client, but it may not, what's related, what's the solution going to look like, and how does a client get out of that, may not be directly related to talking about, for example, depressive symptoms, when the solution has to do with maybe getting out of a bad relationship or repairing a relationship or something along those lines. And so the focus really is on identifying what would a preferred solution look like and taking very small, concrete steps to move in that direction. I think it's really important to talk about that solution-based therapists are not solution givers, and there's a lot of misunderstandings. I actually have a special section. We're going to talk about the myths about solution-focused therapy. It's so, I think, misunderstood, sadly. So they're not solution givers. The solutions come from various techniques that are used to kind of access client strengths, existing resources, what works for them, what they think is going to work for them. And so it's not like the therapist sits there and comes up with a good idea or a solution and hands it to the client. And that really is more along the lines of what cognitive behavioral therapy does. It's like you're having depression or anxiety or marital conflict, and, I'm going to give you these techniques as a therapist to address those. And so another valid approach to therapy, nothing necessarily wrong with it, but it's not solution-focused therapy to be doing that. And so solution-focused therapy definitely falls more within the postmodern tradition, even though it kind of grew out of the MRI approach. And so it's very much language-based in working with clients to construct new realities. But again, there's very much the client does leave this session every time with very small, steps, action steps that they can take towards realizing their goals. And in that way, I can say it's definitely similar to the cognitive behavioral therapies, that typically clients will leave with an assignment of something to do specifically different that's very measurable over the week, and that's given to them from week to week. So before we get much further, I really want to get into addressing some of the common myths and misunderstandings about solution-focused therapy. So the first common myth is that solution-based therapists propose solutions to clients, and there's nothing further from the truth. That's the opposite of what they do, and again, that would be a more cognitive behavioral approach to propose direct solutions. And more family systemic approaches, there are solutions aren't given, but maybe directives are given to help clients, to help the system reorganize. So the main group of therapists that would give homework assignments that would be something along the lines of giving solutions would be the more cognitive behavioral traditions. The second myth is that solution-based therapists never talk about the problem. That is obviously not really possible in most cases, but solution-focused therapists talk the minimum amount necessary about the problem. And because they believe that problem talk isn't necessarily going to be directly related to the solution and what that's going to look like. And so, yes, they will talk about clients that, understand why they're there and they're empathetic and warm, but they also don't dwell there. Most of the techniques that they have are geared towards identifying preferred solutions and taking small steps as quickly as possible, basically in that direction. Another myth is that solution-based therapists never talk about the past. And again, obviously, this is a gross misunderstanding in that, if, for example, a client comes in with a child abuse history, of course the therapist is going to talk about that. But the therapist is also going to be focused on how did that child abuse, how is it affecting the client today? And how does a client want their life to look? And how do we take small directions in that direction? And of course, we talk as much about the past as necessary to move forward. And with every client, that varies. Another myth is that emotions are not discussed. And obviously, again, that doesn't even make a lot of sense. You still need to build rapport, build a relationship. Emotions are frequently discussed, but often they're more positive emotions. So clients, they may come in depressed, and if they leave with, small action steps in the positive direction, it does tend to be a very brief therapy. So often you are talking about positive emotions. But when negative emotions come up, of course, they are talked, discussed, reflected upon, but in very specific ways. So even when you're talking about negative or difficult emotions that the clients want to not have in their life so much, there's a very specific way, and we'll talk about that in a minute, that therapists reflect back the emotion, but in a way that actually defines that, put parameters around that so that the solutions, the possibilities open up. And so again, it's a very subtle use of language, which is very characteristic of a postmodern approach. So now I want to highlight the juice, the significant contributions of solution-focused therapy to the field of mental health. So I believe, arguably, and most people will agree, that solution-focused therapy is the first approach to really harness clients' strengths in a very specific and new way that is, I think most have recognized now, that most approaches would try to do what solution-focused therapists do in terms of assessing client strengths. Because it's one of the most difficult things to do. It's actually much easier to assess psychopathology. Because by the time someone's coming in to see a therapist or a counselor about their mental health or relational issues, they're usually well aware of their symptoms, and that's one of the reasons they're coming in for help. And so, and often things have gotten pretty bad for a person to finally reach out for help like that. So assessing strengths becomes very difficult because most clients come in ready to tell their problem story and talk about their symptoms and everything that's going wrong. And so assessing strengths can be extremely difficult, especially maybe when you're working with a family or a couple, because typically by the time they come in, each person has this very rigid stereotype of the other person. My husband's lazy, my wife is a nag, my son is, defiant, whatever it is. And so they have these rigid descriptions of each other that can be very difficult to see their partners and their children or their parents outside of these almost caricatures that have developed over time as the problem got worse and worse. And so assessing for strengths is a much more difficult, much more subtle and skill, and really does require a fair amount of persistence. And so strengths can be anything. It can refer to personal strengths, relationships they have that are supportive, even spiritual beliefs, and just areas that are working in a person's life. And so, but this is a much more difficult skill. And the truth is, when a solution-focused therapist is sitting there talking to a client, even if the client can go through, I've had clients literally cover more than half the diagnosis, reporting what their problems are, more than half the DSM, diagnostic, chapters, just describing what's wrong. Even then, the solution-focused therapist knows that there are strengths. It is an assumption, it is a belief that is so profound that there's always an assumption that there are strengths, and the solution-focused therapist is going to be curious and exploring how to assess those strengths and identify those strengths. And often you hear it through the exceptions of when the problem's not happening or the problem's not as severe. Sometimes, asking about all the different possible parts of a person's life, about their hobbies, their interests, their relationships. But this is a very, very critical part of solution focus, because it's in by assessing strengths that the therapist is able to help the client identify very realistic and likely to succeed small steps in the positive directions that the clients are hoping for. So now we're going to talk a little bit about some of the major figures in solution-based therapy. So in terms of what I call the behind-the-scenes inspiration, Milton Erickson was a psychiatrist who developed this kind of light trance work that we'll talk a little bit more about. But he was a huge inspiration to both Steve DeShazer and his team, as well as Bill O'Hanlon. And you'll see that a lot of the solution-focused techniques, especially things like the miracle question, there is a bit of a light trance, I believe, that goes with that. It's getting clients to see new possibilities and even being able to envision a life without the problem. So he was a heavy influence. Milton Erickson was famous for his one-session interventions. He was this miracle worker of a therapist, and so he had very brief work, very positive strength-based work, and using a lot of language in very subtle ways. And it's interesting because, on the surface, certain solution-focused techniques really do work amazingly well, even if you don't, understand the theory all that well. I always say it's, scaling question. The basic scaling question can really be used by a therapist or counselor in their first week of work, in their first year of work, with a lot of success. Just using the script, even if you don't quite understand it. But as you learn to master solution-focused therapy, it's very much based on much more subtle use of language. And so when I have my poor students in my class role-playing solution-focused therapy, there's a lot of, I have to have them go back and kind of rephrase things, because we have a very problem-focused outlook here, and problem-focused language, both within the field of mental health psychotherapy, and here in the United States tends to be we use a lot of problem-focused language, and it's a very subtle shift, but it's an important shift. And we'll be talking about some of the specific ways to do that. So the solution-focused brief therapy team that was in Milwaukee was headed by Steve DeShazer and his wife Insoo Kim Berg, who really are probably the biggest promoters of these ideas. And there's also Scott Miller has used this work, Yvonne Dolan. Scott Miller did some of the early work using solution-focused with alcoholics. Yvonne Dolan has done some wonderful work around the working with sexual abuse. Linda Metcalf has taken these ideas into the schools. So there are many people associated with the solution-focused brief therapy who have made amazing contributions in multiple fields within the world of mental health and even broader. Solution-oriented therapy, as I mentioned earlier, is Bill O'Hanlon and Michelle Weiner-Davis. And here you'll see even more subtle focus use of language. And then collaborative strength-based therapy is the specific work of Matthew Seligman. Solution-focused therapy has actually been very popular abroad. There's a European Brief Therapy Association that is very much focused on the solution-based therapy work, as well as a solution-focused Brief Therapy Association that is based in the U.S., although it's also got very international membership here in the United States that carries on the work of Steve DeShazer and Insoo Kim Berg. So now we're going to talk about the process of therapy and solution-based approaches. So as a brief approach, the process of solution-focused therapy is pretty simple. Basically, the goal is to identify small steps to enacting solutions. And, the therapists, help clients identify these preferred solutions usually in the first session. And then each session thereafter, you're identifying, small steps, to enact those solutions, assessing what works, what doesn't. And it's often a very time-limited approach. Having 1 to 10 sessions is not uncommon. Obviously, in certain cases, like, where there's maybe been a long history of child abuse or more complex issues, it can certainly take longer. But it is not uncommon to have it be, 10 or fewer sessions. And next we're going to talk about the therapeutic relationship in solution-based therapies. So in solution-based therapy, the therapeutic relationship really is one of hope and optimism and belief in the client. And so there definitely is a warmth and often even an enthusiasm. You can watch Insoo Kim Berg if you want to see how that is demonstrated. But there's almost like this excitement about the client and their the steps that they're making towards change, and it's a very positive, warm relationship typically. The therapists they talk about using the Zen of viewing, using a beginner's mind as they listen to the client's story. And so there's this not making assumptions, and just because the clients say something scary like hallucinations or psychosis or bipolar, or talk about divorce or whatever it might be, the therapist still keeps a very, very open mind as to still assuming that there's strengths and resources, looking, of how to harness this. And regardless of the words spoken, there is this kind of openness to not only what the clients are saying, but not bringing all of our professional assumptions into or onto the client and projecting our professional assumptions onto the client as to what those might mean. Then another thing that they do is they echo the client's key words back. And so they listen for client language that makes the problem more solvable and engenders hope. For example, if a client comes in saying, "I've been feeling blue lately," the therapist is not going to, they're going to use the term blue instead of using the term depression or even major depression, which are more clinical terms. And the reason is that, addressing and finding a solution to feeling blue, most of us would find to be an easier problem to solve than to, solve the problem of major depressive disorder. And so just the word languaging and the word choice, and they use the client's own language rather than choose diagnostic language, just because typically in most cases the client's language, the problems are easier to solve. One of my favorite ideas that comes out of solution focus is this term Carl Rogers with a twist. And the twist, so in this case, this comes out of the work of Bill O'Hanlon and Michelle Weiner Davis, and they're talking about reflecting emotions or reflecting back to the client with, what's going on, but with a twist. And what the twist is, no matter, whatever the client has said, they try to find either time limits or contextual limits or situational limits about whatever they're saying. So if the person comes in saying, "Oh my God, I've been so depressed since my, girlfriend or boyfriend left me 3 months ago." So rather than just reflecting back the emotion, "Oh, you feel depressed, you feel rejected, you feel abandoned," the therapist would add the contextual or time frame, so over the last 3 months, you've been feeling, really down and blue that your partner left you, something along those. But just even putting the time limit on, so not just ever reflecting, thoughts or emotions back the way the client's saying them, but always kind of circumscribing them in a way so that the problem becomes less big, less overwhelming, and more solvable. And so there are many ways that therapists can do this as clients come in, and it's a very subtle art to master. That's a much more subtle use of the language. But it's amazing how that can start to shift some of the hope. So like I have had a lot of clients come in, complaining of depression. But when you actually, assess their day, so, you wake up feeling very depressed in the morning, and when you go to work, it's like you're not depressed at all. You're totally fine at work. But once you come home again, the depression takes over, and then you're depressed. So there are about 3 hours, on either side of your work day where you're pretty depressed. But for those, 8, 9 hours of working, you're not depressed. So all of a sudden by, just putting those, describing what the client just told you, but with the twist here is that they're actually not depressed more of the day than they are depressed. In this, and I've had more than one client come in like that. It's like, oh, wow, that's not so bad. Similar. So those are the type, that's called Carl Rogers with a twist. It's a very more subtle skill, but it's very powerful in creating a sense of hope and creating a sense of possibility and identifying the what potential solutions might work for the client. So this optimism and hope just exudes from the therapist, and you can watch almost any solution therapist, focus therapist in action, and this is unmistakable, that there is just this radiant sense of hope and belief in the client that things, they can take steps to improve their situation. And there's always this basic assumption, like I've said, that there are solutions, there are possibilities, no matter how severe it may look, that there's always some way to, there's always a potential solution or way to at least improve, maybe not make everything go away, but there is potential solutions and possibilities. Now clearly, just the therapeutic relationship has some basic elements of viewing the clients at a broader level, and now we're going to talk more directly about some basic case conceptualization in solution-based therapies. So the first area of case conceptualization is exceptions and identifying what works. And so oftentimes clients will spontaneously just offer exceptions and examples of what works. So, his ADHD is less of a problem in his math class or in sports. So these are often spontaneously offered. But other times, therapists can ask questions like, when is the situation better? When is it less worse? When is it not as severe? And depending on the client and how pessimistic they are, different word choices might work better. But you're looking for even slight variations in severity, times when the problem's slightly better, not quite as bad. Or even, when is it worse? And so if you can ask when it's worse, then you're looking from there you can ask when is it better? And there is this kind of tricksiness you'll sometimes see in solution-focused therapists, because for some clients it's very hard to even let go of the problem story and their identity around that, because maybe there have been a lot of arguments in the family or with a couple, or that's how they relate to a lot of people through their symptomology, whether it's like a depression or OCD or ADHD. And so sometimes they don't even want to admit that the problem's worse at times. It's almost just hard to let go of that story more than anything else. But the exceptions can be very, very powerful in identifying what works and what the client needs to do more frequently. And sometimes just by identifying exceptions, and the client begins to realize, oh, wow, you're right. It's true. When the TV is not on, they can get their homework done fine. So I guess we need to not have the TV on, or whatever it might be. And so this idea of identifying what works, sometimes exceptions become very, very clear, and sometimes it's a much more subtle process. But it is one that takes, again, a bit of persistence and curiosity, keeping that beginner's mind really open as to what might be happening, because sometimes, again, it's just not so obvious as to what works when and why. So another important set of techniques or interventions within solution-based therapies are the miracle and solution generating questions. And these are very specific questions that are asked to help the client envision a future without the problem. And this intervention actually covers multiple, elements, in terms of, the therapeutic relationship, generating hope and motivation. It helps case conceptualize where are we trying to go, what does that look like. It's also an intervention that, for many clients, they haven't even envisioned a life without their problem. They've lived with this problem for so long. And it also helps you target goals, and it gets very clear what type of goals we are reaching for. So there are many variations: the miracle question, the crystal ball question, magic wand, time machine, but all of these are questions. And really, I think the solution-based brief therapy, or solution-focused brief therapy work of Ensu Berg and Steve DeShazer has the most developed approach to delivering the miracle question, which is actually a very difficult question to deliver. It's, I think, a very advanced technique to do it well. But the gist of the intervention is tell the client, set them up, that you're going to ask a kind of strange question. And this helps kind of prime the client for thinking a little outside the box, and that's very helpful because, like I said, for many clients, envisioning life without the problem is unimaginable. And then you slowly, and this is where I think you see some of the influence of Milton Erickson here. You walk them through, imagine that you leave this, appointment, and you get in your car and you drive home and you have dinner with your family, doing whatever you think is the normal routine of this client, and you have them imagine that. And they're also, Ensu Kim Berg has actually several subtle places where she actually makes sure that their client's nodding their head and following along. But you get them to the point where you imagine that during the night, a miracle occurs, so that all the problems you came for were miraculously resolved. But when you wake up in the morning, you don't know that there was a miracle. And so then you have them walk them through the day, and what's it like when you wake up? What are some of the first signs you might see, or what might be different that might give you a clue that a miracle has occurred? And you slowly walk them through this, envisioning what this miracle day looks like as they kind of discover the problems have all been resolved. And it takes a lot of skill to actually ask the follow-up questions in a useful way. Because often they'll wake up by saying, I'll wake up and I won't be depressed anymore. Okay, so what will you be doing differently, and what will be different? What will you be doing differently if you're not depressed when you wake up in the morning? And so you keep having the clients identify what they would be doing differently, or others might be doing differently in a couple or family situation. What the client's actually doing different in this miracle day, and focusing on those behaviors. It's not about, when you start getting a wish list of, there's a Ferrari in the driveway and I wake up in a mansion, or I wake up, on my dream vacation, whatever it is. What you want to do, you can just some clients are like, see, the question didn't work. That didn't work. The client didn't give me the right answer. It's about the therapist knowing how to set it up correctly, and then ask the follow-up questions so that you get the useful behavioral information. But when asked skillfully, this question, first of all, for a lot of clients, it's just liberating to even imagine this day, and then to be carefully walk through this day and to identify what this person's doing differently. Well, I wasn't depressed, so I got up and I went for a run, and tell me what what did you enjoy about that? You can even ask them questions, and then, what's the next thing you did? Well, I came home then and I ate a healthy breakfast, and I, kissed my wife, or I played with my kids in the morning, and I took the kids to school, and we sang songs in the car, whatever it is. But you have them envision this whole day, and through it, though, you get a lot of information of what they want their life to look like. You've also engendered hope. You've identified your goals. Most of what you need for your treatment plan is done. And you now have most of what you need to do to proceed. And then what you do is you break that down into little steps, and we'll talk about the scaling questions. But from that, you can say, okay, so where are you today in terms of 10 being your miracle day? Where are you now? What would be the first half step or whole step, in that direction? And that's pretty much how they work. And most solution-focused therapies will will follow basically along that process. So another common element of case conceptualization, which also trickles into kind of just assessing progress along the way, is scaling questions, or sometimes the miracle scale. So scaling questions ask clients to define their goals and rate progress using usually a 0 to 10 scale or a 1 to 10 scale, with 10 usually being, again, where you want to go, and 1 or 0 being where you are right now. And so scaling questions, though, and along these miracle scale, obviously, would be when you're specifically, with 10 is what the miracle day looks like. But there are numerous applications. You can do it in the beginning for a long-term goal setting, kind of seeing where they're at, assessing where things are week to week, assessing what works, and just measuring progress along the way. But just asking the question, where are you now? Oftentimes in the first session you would ask, so where were you on this scale when you first picked up the phone to call, and where are you now? And so oftentimes I've had clients say, well, I was at a 1 when I finally picked up the phone to call you, right now I'm at a 3. Wow, so what happened between the phone call and now to move you up 2 points on the scale? And so having, so this can be a very, very powerful intervention. Again, you're identifying what works, you're identifying exceptions, and being very clear and help, and even the client becomes often very hopeful. It's like, wow, I am actually quite better from when I called already, because whatever happened in between. So even when they attribute it to something external happening, like I had a surprise birthday party at work, you want to go back and ask about their agency, and even something that seems external. So what did you do that helped make, it's very nice that your coworkers did this for you, but what did you do in terms of being receptive to that party that made it really enjoyable for you, where you've moved up 2 points on the scale? So then again, you always want to go back to what is the client doing to make things, so the client can say, well, at first I thought of, I was angry and I was not in the mood, but then I realized, oh my gosh, this is, these people do really care. And so I softened and I allowed myself to have a good time. I was thankful and gracious. I avoided the people who annoy me, whatever it might be. But you would have them identify what was their part in making it successful. And here are some examples of what the scales might look like. So here's the miracle scale, when you decided to seek help in your miracle situation. The worst to solution scale, so things at their worst, where they are today, where they're going to be, where the solution is. And again, these are really wonderful for just structuring therapy sessions. I always tell my students, if you go in and you don't know what to do, just ask a scaling question. Where are they now? Where do they want to be? And what small steps can you take over the next week to make that happen? And that should fill up a 50-minute session if it's done correctly. It's relatively, I guess, simple and straightforward. It's not easy, though, and it's actually a lot more difficult to do than it looks on the outside, because it does take a very different perspective in terms of picking up all the subtle exceptions and subtle strengths that often are not the first thing a person would see or hear when a client's describing their situation. So now we're going to move on to talking about goal setting. So the solution-focused approach actually uses goals that are very positive and observable, concrete, and measurable. And so actually this is an approach that is widely used in managed-based healthcare or government agencies where they want a lot of very clear goals. But the goals in solution focus, they always want them to be stated in positive terms, what the client will be doing rather than what the client won't be doing. And this actually comes directly out of an Ericksonian hypnosis tradition, where you focus on the mind, whatever you're envisioning, whether you're envisioning it not to do it or doing it, it's about the same thing for the subconscious mind. So that's where they keep all the terms and what you will be doing differently, not what you won't be doing differently. And again, they want the goals to be observable, measurable, very clear, so that everyone knows when the goal is achieved. And again, this is a very common requirement of mental health clinicians, regardless of their theoretical orientation in today's work. So here you can see some examples of observable versus non-observable goals. So like a negative symptom reducing goal would be to reduce depressed mood or to reduce depression. But the more positive behavioral goal is to increase periods of enjoyable activity, social interaction, etc. Again, reducing couple conflict would be a negative symptom-based goal where, increasing frequency of the couple's, emotionally intimate connection and communications would be a much more positively stated goal. Reducing defiance. Instead, you're going to increase, cooperation and pro-social activities, and then you'll need to do so in a way that's clearly measurable. And so you're going to get even more specific, which is going to be, to be defined, as helping out with the dishes or not, cooperating with siblings or whatever it might be. But you want to have it stated in positive terms and clearly measurable terms for that specific client. And so finally, just some other tips here on writing solution-based goals. They need to be meaningful to the client, not just to the managed care company. They need to be, interactional in terms of what a person would be doing. Be clear into what situations and contexts the behavior will be happening at home, at school, at work. There need to be small little steps defined along the way. And there needs to be a clear role for what the client's going to be doing differently. Many clients will come in wanting the world to change so that they're not so stressed out. Obviously, that's not, there's no role the therapist has. So you need to make sure it's very clear what the role is for the client. And if they're multiple, if you're working with a couple or a family, it needs to be very clear what each person's role is in that system. The goals need to be very realistic. So just because, I've had multiple couples come in with the hopes that I would teach them how to never, ever need to have an argument again. And I don't know if that's really realistic, but I want to teach them how to have conversations about difficult topics where they disagree in a respectful way that strengthens their relationship rather than deteriorates it. So I can't make all the difficulties of living with another human being go away, but I can certainly help couples and families find much more respectful ways to navigate those difficulties. And obviously the goals need to be legal and ethical. So, if a couple or client comes in and their goal is, to do things that would not be considered legal or ethical, let's say along the lines of, intimate partner violence or such, and that, not that someone's goal will necessarily, be to use that, but the therapist doesn't say, oh, well, the family agrees, that's their reality, that they want to have violence in their household. Obviously that's not something a therapist is going to agree with, even if they're working within the client's reality. There are clear legal, ethical boundaries. So now we're going to talk about the doing and interventions in solution-based therapies. Solution-based therapists have lots of different, interventions that they use, but they have some basic tenets when they think about intervening with clients. The first, if it isn't broken, the client's not complaining about it, don't fix it. If it works, do more of it. If it's not working, do something different. They focus on small steps leading to big changes. They also talk about how the solution isn't necessarily related to the problem. The language for solution development is different than that needed to describe a problem. So solution development needs solution-focused language, solution-based language about what works in positive terms, not what we don't want, but what do we want in its place. So, for example, again, the problem of depression or, panic or anxiety, all of that, is that problem language, but what the solution is going to look like to all of that in each individual client's life usually doesn't involve any of that language. It's a very different, I'll be up exercising, I'll be hanging out with my friends, whatever it might be. I'll be back to doing my, favorite underwater basket weaving hobby, whatever it might be. So that's where they're talking about the language of the solution isn't necessarily related to the problem. Another real important assumption is that no problem happens all the time. There are always exceptions, and we look for those exceptions, and sometimes they're hard to find. But you look for those exceptions, and you identify when those happen and see if we can find a way to bring those into the present to move things in a more positive direction. And the final assumption is that the future is both created and negotiable, and this again is part of their kind of postmodern underpinnings. So one intervention that can be used often in the early stages where clients maybe don't feel like they got as much hope and they're feeling kind of pessimistic is to have them do just one thing different. And so you want to have them, perhaps when you're doing a scaling question and it's clear the client thinks that, they're at a 3, they, getting to a 4 may be pushing things. You can say, well, what might get you to a 3.5 or 3.25? And then you have them identify one small thing different. Because oftentimes people are like, who, let's say they haven't exercised in 4 years. It's like, well, I'm going to start running every morning. And I might say, that seems a bit ambitious. What if you go try to run or go for a walk one morning, or go for a run for one morning or maybe 2 mornings, and to have one small little thing different. To have them maybe reorganize some part of their day that might be significant or meaningful. Maybe it is over the course of the week, I want you to pick up the phone and call one person over the course of the week if they've been isolating themselves, rather than trying to call someone every day. And so again, even just one small thing different, it creates this small cascade of change. And many clients, if they're coming in and feeling very hopeless or pessimistic, stuck, if you ask them to do too much at once, they're not going to do it, and then they feel even more helpless. So you want to be very, very careful that when you assign something, it's realistic and doable for the client. But it's amazing, they have one little success often creates this cascade of other positive outcomes. Some other common interventions in solution focused include the formula first session task. And it's called the formula first session task because it is a formulaic question you give in the first session. And this was used in the early work of Steve DeShazer and Insoo Kim Berg. It's one of their earlier interventions. But basically, in the first session, you ask clients to go back. You're coming to therapy now. A lot's going to be changing, but we don't want things to change that are working. So, can you, over the next week, I want you to identify what is working in your life that you don't want us to change. And again, this helps shift their perception to look at what is working that they do like about the relationship. It's a very powerful intervention that helps them begin to shift their perceptions during the week and notice what's working. We've talked already about the scaling questions for weekly task assignment, and that's using that scaling question. You're at a 3 today. What would it take to get to a 3.5 and a 4 next week? And actually behaviorally define that in actual steps that are totally realistic for this particular client, at this period of time in their life, that fills an entire session in and of itself. And it usually can be very helpful in helping clients move in the right direction. There's also asking what are called presuppositional questions. So solution-focused therapists, and this is sincere, it is not manipulation, but they sincerely believe that clients are capable of change. Problems are, can be solved. And so they presuppose. So when, you've reached this kind of miracle day in your life, or when you've resolved the problems you've come here to, so they're assuming it in the question that the client's problems will be solved. And that is just an assumption. These presuppositional questions, again, help the client envision life without the problem and help them identify what they would be doing differently in the future. Utilization, that again comes out of the Ericksonian hypnosis technique, where that you utilize whatever the symptom is. You find ways to take that and put it in a different context so that it's helpful. For example, clients who tend to be perfectionistic or anxious, they tend to be really good planners. I always like to joke, if I'm going to, hire an assistant, I want them to have just a touch of OCD in them because all the details are going to get handled. So, so what you would do though is, identify whatever this is and see if you can find ways. So you got a client who's got anxiety or OCD tendencies. How can they use those exact same symptoms to help them, take small steps towards their preferred solution? And so this can very easily be done again with the planning skills of anxiety or in depression too. They tend to be thinking about potential problems, in the future. So how can you use that skill to problem solve what might come in the way of the client interacting their preferred solution? Another great set of questions or interventions are coping questions. especially when the client has gone through, very difficult situations like, rape and loss and child abuse or whatever it might be, domestic violence. So how have you coped, with whatever these difficult circumstances are? And so it can be asked in a very compassionate way when clients are dealing with very traumatic events, and yet in a very hopeful way. In terms of helping generate hope for the client and realizing their strengths and realizing and acknowledging what they've overcome. So compliments and encouragement are also used frequently in solution-focused therapy, but it's important to note that it's not cheerleading compliments. They compliment the client when typically it's, you want to be very careful with compliments because you can inadvertently impose the therapist's values on top of the client. So you want to compliment the client in successfully taking those small steps towards their preferred solution. So you're not putting values onto the client. You're saying, wow, you said, you wanted to, you said last week that you wanted to make a phone call. One friend was your goal over the week, and you actually called 3. That's amazing. And how long on the phone? Wow, that's very impressive. So again, you're complimenting them on their goals that they've set, so that you're not putting your values and beliefs on the client. And I just want to quickly highlight solution-focused work for working with sexual abuse and trauma. In particular, I find this solution approach can be particularly useful for trauma victims because it is optimistic, because it is hopeful, and because it really identifies and helps clients experience their strengths and their resilience, and to see that they are survivors, not just victims. And so this focus on the agency can be extremely empowering for someone who's gone through abuse, especially something along the lines of sexual abuse. They use a recovery scale where normally you just measure people's negative symptoms. They have Yvonne Dolan has developed the recovery scale that helps clients. It's a multi-question survey that helps them identify where are you still functional, where are things still working, or where are things not so bad. And just filling that out can be extremely reassuring and hopeful and very, very powerful for someone who's gone through something as difficult as a sexual abuse or sexual assault. They talk about working with, there's a 3D model with how they work with the dissociation and similar symptoms. And they talk about using constructive questions that help clients identify effective ways and solutions, ways to take what's in the areas of their life where things are working, how can you transfer that to areas where things aren't working so well. They use a lot of video talk, and that is where you separate. So video talk is when you describe first, what someone, if you had a video camera, what would I be seeing going on, maybe while you're having your flashback, or what would I be seeing going on at work or at home or in your relationship. And then you separate that out from the interpretations. And so then you look at, well, how is a client interpreting all of those events? And it can be very helpful in kind of looking at those interpretations, where are those often very pessimistic or negative interpretations coming from, to help clients find new ways to, viewing themselves as well as significant others in their life. So now we're going to talk briefly about the research and the evidence base. The evidence base for solution-based therapies is actually rapidly growing, and it definitely has a very respectable empirical support. That it does have a solution-focused brief therapy has a modest effect size and equivalent outcomes to most other forms of therapy, and it typically does so in less time and at less cost. And so it is an approach that is definitely supported by a lot of community-based agencies that have tight funding sources as a preferred approach. And it's actually been shown to be effective with quite a wide range of clinical populations, including domestic violence offenders, couples, schizophrenia, child abuse, troubled youth, in schools, with parenting, alcohol abuse, foster care. So there are a wide range of clients that this approach has demonstrated effectiveness with. So it is not a formal evidence-based treatment specifically, but it has a very solid and definitely growing evidence base for its use with a wide range of clients. And now I also want to talk about working with diverse populations using solution-based therapies. In general, because solution-based therapies do not have a theory of health and what that looks like, of either psychological health or relational health, it is more easily adapted to various cultures because it is very much based on what the client identifies as their preferred solution. And so it is used widely around the world, both North and South America, Europe, the Middle East, Asia, Australia. It's a widely used approach, and it's very adaptable across cultures. When used as it's been developed, which is without imposing therapeutic assumptions about what health looks like. And it's actually been used, it seems to transfer very well because of its brief nature and its positive focus. It transfers very well to many other contexts besides the mental health world. It's used widely in schools, probably the most frequently used mental health approach in schools, used in prisons and hospitals. It's used in businesses. It's used in college counseling. It's used in many different arenas because of its strength focus, because it's so practical. It really is a very adaptable approach. So it's considered, some of its strengths are, it's a very behavioral, and its focuses on behavior is always considered within context, not by some predefined psychological norm. The goals are very client-generated, and it has a behavioral rather than an emotional focus, which does allow it to translate well across cultures, because there are various cultures where focusing on emotions is just not part of or highly valued within the culture. And also the future orientation is often a very safe, and for cultures that are very, we have here the Asian Americans. In particular, this has been used with Asians because it is one of the few approaches that allows a client to save face, which is very important within many Asian cultures. Because things are positive. You're not talking about people's strengths. You're not airing dirty laundry out, but you're recognizing people's strengths and abilities, and it's focuses on very pragmatic solutions. And that's not to say that, emotions are not focused on, but they're done so in a way that allows clients to maintain a strong, clear sense of dignity. So this is some of the reasons why it has been used, especially in Asian cultures, where most mental health approaches are not as don't allow a client to save face in the same way. And even though you may not be talking about emotions very directly, you nonetheless depression gets alleviated, anxiety gets alleviated. They have the same outcomes as other approaches. So it's a very it can be a very culturally sensitive approach for any client who comes from a background or immigrant. Many immigrants from such as from Africa, they talking about your emotions and putting that out all over the table. It's very 21st century American value, but it doesn't always fit with other cultures around the world, and so it's a nice approach when working with diverse clients. So I hope this has been a useful introduction to solution-focused therapy. I hope one of the things you take away from this discussion is that solution-focused therapy, it looks very simple and simplistic on the outside, but it's much more, involves a lot of very subtle skills, language, ways, not only how you language things, but how you view your clients and the assumptions you make. And so it's a very, very important, I think, set of skills for really any contemporary therapist and counselor to develop, is the ability to identify client strengths and resources. And that is a much, much more difficult task than one would think. And I think a lot of people say, I asked about client strengths, there's no one question you can ask to do that. And it's a whole mindset, it's the way you view clients, it's the way you listen. It's very, very subtle. So the more you practice solution focus and get trained in it and learn about it, you begin to realize what a very subtle art form it is. And that said, at the same time, for someone in their first year of training, it's a wonderful model that to begin with in terms of working with very clear interventions like the scaling questions to help you figure out how to structure and help clients identify what might work. So I hope this has been an enjoyable and useful introduction, and I encourage you to learn more about this very pivotal technique in our field and influential.